the webinar. Let me see. Just got it. Hello, and thank you for joining us for this evening's presentation, Mucogingival Therapy, Gingival Grafting. I'm Dr. Sam Joachim, Chief Dental Officer for Zufall Health Center. Before we get started, just a few housekeeping items. You will be entering this presentation on mute. If you have any questions, please use the Q&A feature to chat in your questions. And please remember to complete the evaluation to receive credit for tonight's presentation. The evaluation will be found on our website, which is zufallhealth.org/CDE. So after this evening's presentation, you will be able to find the survey link. If you visit the website, in the top portion, you will find our upcoming courses where you could register for upcoming courses. And right below that, under past courses, you will find tonight's presentation along with a survey link. You click on that for up to a week following tonight's presentation to complete the survey. Once the survey is closed, the certificates will be issued to participants. For those who are joining us for the first time, I'd like to welcome you to Zufall Health Center. Zufall is a federally qualified health center in Northwest and Central New Jersey. It was founded in 1990 by Dr. Zufall and his wife as the Dover Free Clinic and has grown since to 8 clinical sites, 7 counties in New Jersey, and cares for over 41,000 low-income and underserved patients. Tonight's presentation is provided thanks to a generous sponsorship by Delta Dental of New Jersey. In addition to sponsoring the Delta Dental Clinical Excellence CE series, Delta has been a supporter of a number of our programs, including the Zufall Health Delta Dental Mobile Unit, the Smiles for Our Heroes volunteer program, the new West Orange building that has a new dental department, as well as the Rural Oral Health Conference, which is coming up on November 18. It is a CE conference, and you will find more information on that on our website. Couple other initiatives. We also have a number of dental residency programs, one in partnership with NYU Langone and our Dover site, and we are in the process of putting together our own residency training program in our Hackettstown site, which will be launched within the next couple of years. And if anybody's interested in supporting us in these efforts, if anybody's local and would like to volunteer, please feel free to reach out to me. And anyone interested in making a donation, please feel free to visit our website at zufallhealthfoundation.org/donate to help support our programs. So I would like to introduce our guest for this evening. It's Dr. Scorziello, who completed both his DMD degree and periodontal training at the University of Medicine and Dentistry of New Jersey, the New Jersey Dental School, now Rutgers School of Dental Medicine. Dr. Scorziello is a diplomat of the American Board of Periodontology. He teaches both didactic and clinical periodontics part-time at the Rutgers School of Dental Medicine and maintains his own private practice. He also is a clinical attending at Zufall Health and participates in resident training. Dr. Scorziello lectures locally in New Jersey and has given numerous periodontal lectures in Germany as well. We are pleased to have Dr. Scorziello join us today as our speaker, and I turn it over to him.
Thanks very much, Sam, for that nice introduction. Let me get started here. Just give me a second to, okay. Okay, so tonight we're going to, is my title slide visible?
Yep.
All right, good. All right, so tonight we're going to talk about mucogingival therapy, specifically gingival grafting, and we'll talk about a couple of different types of gingival grafting. I also want to tell you I'm not affiliated with any of the products or companies shown or discussed in this presentation, and there will be some specific products that I will mention. Okay, so let's jump into the presentation. All right, everybody usually thinks of periodontics as what you see on the screen here. Now, what you see on the left is the same patient that you see on the right. It just happens to be about 18 months after her periodontal therapy with me. Every time I look at this, I realize my parents absolutely got their money's worth on my tuition. But basically, this is something that periodontists do. We can take a patient from this to this, but this is not all we do. Obviously, we do guided tissue regeneration. We may do some bone grafting. We may do some implants. But everybody thinks this is the bulk of what we do. And yes, this is a big part of what we do, but we also do things with gingival grafting, mucogingival therapy. So that's what we're going to talk about today. All right, so what is mucogingival therapy? It's simply periodontal surgical procedures. So they're all the mucogingival therapies are surgical procedures. We use them to correct defects in the morphology of the tissue. So maybe the tissue is thin and we want to thicken it up. That can be a change in the morphology. We want to change the position. Maybe there's gingival recession from somebody brushing aggressively. And actually, aggressive brushing is probably one of the absolute most common reasons why people get gingival recession. So we want to correct the position of the teeth, or we simply want to give them more tissue. Some patients have keratinized tissue, and we want to give them more attached keratinized tissue. So mucogingival therapy really deals with attached keratinized tissue around teeth. And not every area of recession needs to be treated, but some areas do. And it also will depend on what you're hoping to accomplish with the restorative work for the patient. This is one of the dental students at our dental school. I took some photos. So this is just to show you what normal, healthy, attached keratinized tissue would look like. It's pink. The band of tissue is wider in the maxillary anterior sextant, and as you move posteriorly, you can see here, it narrows out a little bit, then it widens up again as you head posteriorly. And normally in the mandible, the zone or the width of the attached keratinized tissue is narrower than in the maxilla. And this tissue is here for a reason. Most people, when they smile, they like to see this pink color. So for patients, it looks aesthetic. So when you do restorations, you obviously want to try to have some of this nice, healthy pink tissue. It makes everything look aesthetic. But from a periodontal or biologic standpoint, aesthetics is not the primary reason it's there. This tissue is very thick and tightly bound down, and it acts as a barrier against inflammation. If you didn't have this thick keratinized tissue, the gingival margin would move back and forth, and if it continued to move, you would simply have a lot more plaque or even food particles getting under the gingival tissue, and that would lead to more inflammation. So you will see patients where they have a lack of attached keratinized tissue. They may not have any, and the tissue is chronically inflamed and red. So in that instance, you probably need to do something. But the main reason for this tissue is not aesthetics. From a dental point of view, it acts as a barrier against inflammation. And you're going to want that when you do restorative work or put in some implants. You want that to act as a barrier. And we'll touch on that as we go ahead. All right, a couple of different procedures that I want to talk about tonight. I want to talk about a free gingival graft. A free gingival graft is a very well-proven technique, a surgical technique to increase the width of keratinized tissue. So it's been done probably for the last 60 years, and it has very good results. It has limitations where it can be done, when it can be done, and has limitations aesthetically, but it is actually something that periodontists do quite often. Connective tissue grafting is another type of mucogingival therapy, and it's done for a very specific reason. It would be totally different than when you'd want to do a free gingival graft. A lateral sliding flap will be something else that I'll show you one surgical procedure. An apically positioned flap is something that periodontists can do that can increase keratinized tissue. You'll see a little bit about that. And I threw in pinhole surgery because over the last 10 years, pinhole surgery was something that was touted a lot in the media, in the news. And it's a specific type of surgery to treat mucogingival defects, but very specific mucogingival defects. And in order to do pinhole surgery, you need to take a course out in California. You need to actually use their instruments and follow. They have a patented technique and patented instruments for doing their surgical therapy. So you need to be pinhole certified. I am not, but I have a periodontist friend who is, so she gave me a few slides just to throw in here just for completeness. All right, now, whenever you see any type of recession, if you're going to think about treatment, you need to classify the recession. There are multiple classification systems that are used for recession. The system that I was trained with in dental school and in the periodontal training was the Miller classification system. Right now, there's also the Cairo system. We'll talk about that in a minute, but I just want to simply focus on the Miller classification system. So Miller has 4 divisions. Class 1 would be you have no recession beyond the mucogingival junction, and you have no loss of interdental bone or soft tissue. So if you look at this clinical slide, you can see number 6 and number 7. There's probably 2 millimeters of recession on the canine, 2 millimeters on the lateral. This patient has a very wide band of attached keratinized tissue. So there is some recession there. Does it need to have treatment? Absolutely not. If the patient said to me, I want to do something for this, I don't like how it looks, or I don't like how it feels, then we can think about doing something. And it's a class 1 defect because the recession doesn't go beyond the mucogingival junction, and you haven't lost interproximal bone or soft tissue. To know where the bone is, you'd look at an x-ray and you'd also probe, and you can see that you haven't lost tissue. And it's very important, the interproximal height of the tissue and the bone, that determines how successful you're going to be because, sorry, on these areas interproximally, your blood supply is coming through here, and you can't violate basic biologic principles. Basic biologic principles say where the blood supply is coming from, that's going to determine the height of where you can get any type of coverage on the tooth. So since the tissue goes all the way into the embrasure area and fills it, you can expect to get 100% root coverage with a procedure if you did something here. So again, you need to know the classification of the defect because that's going to help guide you with the treatment. Now, I mentioned sensitivity. If the patient said to you, these 2 teeth are very sensitive, every time I have a drink of water, it bothers me, every time I have a cup of tea, it bothers me, and I don't like to brush the area here because when I hit it with my toothbrush, it's sensitive, then I would say, well, you should have something done to correct this, because if they can't enjoy a drink of water or a cup of tea, they're missing out on a lot of stuff. So I would want to think about correcting it. If they told me the area is so sensitive that they don't like to brush it, I get concerned as a dentist, because if they're not brushing, they're going to be prone to decay in this area, and they're going to be prone to some gingival inflammation. But if they just came in and I saw the recession, and I asked them if this bothers them, if they said, no, we don't necessarily need to do anything. So not every area of recession needs treatment. Okay, so now a Miller type 2 class defect would be recession that goes at or beyond the mucogingival junction. So if you look at this premolar, there's a big cleft in the tissue here. So here's the mucogingival junction. So this recession goes just about to the mucogingival junction, but there's also no loss of interdental bone or soft tissue. So we have high levels of tissue and bone interproximally, meaning we could predictably get 100% root coverage on this with one of the surgical techniques that we would decide to use. Right. A Miller type 3 defect means your recession is at or beyond the mucogingival junction, but you have loss of interdental bone and soft tissue. So this patient came in to see me. By the way, all the clinical slides you're going to see are patients that I've treated, except for the pinhole slides, but everyone else I've treated. So this patient came in to see me. You can see she has a great deal of recession on these teeth, but she's also lost a lot of soft tissue and bone interproximally. So if I were going to do something on this lateral incisor in this canine, I can only hope to go as high as the interproximal tissue. So I would never, ever promise this patient root coverage, because I can't cover the root because we've already lost the interdental soft tissue. And that's why it's important to know the classification system. You need the classification system. You'd give the patient a diagnosis. I would say this patient has a Miller type 3 defect. That would be the diagnosis, and the diagnosis is going to guide me for the treatment. That's why the classification system is so important. A Miller type 4 means you have recession that is at or beyond the mucogingival junction with severe loss of interdental bone and soft tissue. So here in this molar area, we have severe loss of interdental bone and soft tissue. Here's the CEJ on this premolar. There's an amalgam in there, but let's just say the amalgam wasn't in there. You could never tell this patient that I'm going to cover the root on here. It'd be impossible. She can only go as high as this tissue here. So you'd only get a little bit of coverage here. And by the way, when there is a buccal restoration, a lot of patients come in and they have composites on the buccal. You cannot cover any restoration, cannot cover anything with gingival tissue. If you hoped to get any coverage here, you will not get it. Nothing will ever grow over composite or amalgam. Sometimes if the amalgam is a very shallow, not amalgam, if the composite is a very shallow piece of composite they put on because the patient had sensitivity, sometimes we can take that off and then we can get coverage into the dentin on the root, but you will never get coverage of any gingival tissue over any type of restorative material. Right. The Chiro classification system works very similar to the Miller classification, except it also takes into account buccal recession. So I don't want to go through the Chiro classification system, just to tell you they have a recession type 1, recession type 2, and a recession type 3. And it doesn't matter whether you use the Chiro system or the Miller classification system. What matters is that you know what type of defect you have, because you need to have a diagnosis, and that's going to guide your treatment. Miller type 1 and Miller type 2 defects, Chiro 1 and Chiro 2 defects, you can expect almost 100% root coverage. So if you don't know that going in, you don't know what to predictably tell the patient. If you don't know what to predictably tell them, you technically haven't given them informed consent. So you need to have just a clear diagnosis, and the diagnosis is going to help guide your treatment. Right. What I want to start with is a free gingival graft. So historically, free gingival grafts have been done since the 1960s, and they were well documented, well explained. The early work was done by Neighbors, Sullivan, and Atkins. And basically what they did was they saw areas of recession on teeth, and they developed a surgical technique for treating that recession, and it was the free gingival graft. And there were limitations to the free gingival graft, just like any other surgical procedure, but it's been around for a very long time, and it's very predictable, and it can give you good results. So let's show you what that means. So if you're thinking of doing a free gingival graft, it's indicated in areas where you want to increase the width of keratinized tissue. So maybe the patient has a very minimal zone of attached keratinized tissue. If you want to increase the width of tissue, this is great. If you want to increase the vestibular depth, it's also going to be very good. Increasing the vestibular depth is going to help the patient with home care because now they have some more room to get the toothbrush in there. You're going to see a case where the patient had a lot of recession. It's going to be coming up, and doing the free gingival graft helped increase the vestibular depth. So these are indications for doing this. Contraindications would be in an aesthetic zone because when this heals, you will get an increased width of tissue, but it doesn't look very aesthetic. So in an aesthetic zone, there are other procedures that you could try. If you have a wide area that needs root coverage, a free gingival graft is probably not the best choice. I am going to show you one case where there was a very narrow area of recession, and I used a free gingival graft and I got root coverage simply because it was a very, very narrow area. So again, I know that from experience going into the procedure. In a very narrow area, I can get some root coverage, but you'll see that in a minute. So first you come up with your diagnosis. You decide, does a patient need to have does a patient need treatment for the mucogingival problem? Is it a problem in the morphology? Is it a problem in the shape, or a problem in the amount of tissue? Then you decide, okay, what is the diagnosis? Is it a type 1 defect, a 2, a 3, or a 4? Once you get the diagnosis, then you can begin to pick the procedure that you think will give you the best outcome. So if you decide that you want to increase the vestibular depth, then a free gingival graft is a good choice. If you decide that you need to increase the zone of attached keratinized tissue, free gingival graft is going to be a good choice. So your recipient site is the area with the recession. That's what's going to receive the tissue that you're going to transplant. So the recipient site, you're going to do a split thickness flap. The split thickness flap simply means that you're going to use your scalpel and you have to split the tissue and leave periosteum on the bone. Now, for all the surgeons out there listening, if any of my perio residents are out there from Rutgers, and I saw my Zufall AEGD crew out there, if we were going to do a split thickness flap, we need to have thick tissue. So that's another thing. You need to look at the quality of tissue. If you don't have thick tissue, you won't be able to split the flaps, and then maybe you wouldn't think about doing this. So there are other things that go into it besides the diagnosis. So again, we split the flap. The donor site is where we're taking the tissue from. You take tissue from the hard palate. You take a thickness of about 3/4 of a millimeter to a millimeter thick. Avoid the area of the rugae, because if you take tissue from there, when it heals, that tissue is genetically programmed to have ridges in it like rugae, and you don't want that to be on the area where you're putting the new tissue. Always stay away from the greater palatine artery, and you can always anticipate tissue shrinkage of about 25%. So when you're taking your donor tissue, you like to take something a little bit bigger than, you measure the area where you want to put it, and you take something about 25% bigger because you know there's going to be some shrinkage. It's always great if your patient is missing their maxillary molars and you can head back towards the tuberosity area, because there is no danger of getting near the greater palatine artery, and the tissue there is nice and thick, so you always get a nice thick piece of tissue. By the way, when you harvest tissue, if you do these, and I think in the anterior sextant you could do these very simple one-tooth procedures, the predictability is gauged on the thickness of tissue that you're going to take. So the thicker the piece of tissue, the better. Right. This was a patient that came in, and if you look at this premolar, you can see that there's some buccal caries. Now, here's the mucogingival junction. There's probably about 1 to 2 millimeters of keratinized tissue, and it's no longer attached because I probed to the mucogingival junction. So someone will say to me, well, is that a problem? Well, the patient's keeping it clean. It's not red and inflamed, but what I didn't tell you on a restorative aspect, this patient's getting a fixed bridge. So there's going to be a crown on this molar. There's going to be a pontic here. There's going to be a crown here. And there's also going to be a crown here. So this is going to be a single unit crown. This will be a 3-unit fixed bridge. Once this tooth is prepped and the impression cord goes in here and the impression material, this little bit of tissue is probably going to tear away. So now you're going to create a bigger defect. And if you do, that's going to be an area chronically red, chronically inflamed. And the patient will say to you, gee, I never had any bleeding there, but ever since you put that bridge in, that tissue is always red and it's tender. Because if it's bleeding and inflamed, it's always going to be tender to them. So we decided to do something pre-prosthetically here before the fixed bridge was made. So a free gingival graft is going to be done. We're not in an aesthetic zone. This is tooth number 29, so we don't have to think about aesthetic procedures. We have to think about our classification. There's interproximal bone and soft tissue here. Here, there's a decrease because a tooth came out. So we know that the tissue can never go any higher than that, than the level here. So we do a split thickness flap here. This tissue is relatively thick. We do a split and we leave periosteum on the bone. And I need that periosteum there because I'm going to suture the donor tissue to it. So here on this tooth number 28, there's probably 1 millimeter or 2 of attached keratinized tissue. So I'm going to do the graft on both of these teeth. I go to the palatal area. I anesthetize with either septicaine or lidocaine. I take a piece of tissue, again, about 1 millimeter in thickness. I measure what I want here. I take it a little bit longer to allow for shrinkage, and I do not take the tissue right up against the gingival margins here because I don't want to cause recession on these teeth. And this will just granulate in. The whole palate's keratinized tissue. This will granulate in with new attached keratinized tissue. All right, so what I do is I take my donor tissue, I prepare my flap here. I can cavitron these teeth to get any plaque off. I will also, if I need to, I'll just scale them a little bit to just get the diseased, the toxins or the bacteria off the root. I simply tack this down with simple interrupted sutures. So I use simple interrupted sutures and I'm suturing it to the periosteum. So they're periosteal interrupted sutures. I like to use a very small needle and usually I use a 5/0 here. This is 5/0 silk with a very small needle. That holds it in place because if you get any movement in this, it's not going to succeed. It's going to fail. So split thickness bed and all of these other areas are going to just granulate in with attached keratinized tissue. This is at 10 to 14 days and this is normal healing. So it's beginning to granulate in. This is the donor area at about the same 2 weeks and it's beginning to fill in. And yes, this area can be sore for patients. So again, when you do this, I tell patients there are 2 surgical spots, the surgical area that's going to receive the tissue and the area where the donor tissue comes from. Right, so now at about 8 weeks, which is 2 months, this is what we have. This is what we started with. This was pre-treatment. We probed to the mucogingival junction. Now at 8 weeks, we've increased the zone of keratinized tissue. We probably have 10 or 12 millimeters of attached keratinized tissue here. Now this is wonderful because when the restorative dentist preps this tooth and preps this tooth, there's going to be plenty of tissue here. Remember, I said it's going to act as a barrier against inflammation. So it's going to help protect this tooth. The tissue will be nice and thick and firm. When the retraction cord goes in here, they won't have any problems. And the same thing when they put the crown on here. It's going to help prevent any inflammation in this area. So for my D3 and D4 dental students that are listening from Rutgers, this is why we want you to do a reevaluation visit before you complete your prosthetics. Because if we have this, we want to do something to change this environment. So here we've simply gone from this to this. We've increased the amount of tissue and we've changed the morphology. And then the patient's going to be extremely happy when he or she gets their fixed bridge. And that's why we do this to you. All right, this was a patient that came in to see me after orthodontic treatment. And she came in to see me because this area was always very sensitive and tender for her. Take a look at her adjacent teeth. She has a great level of home care. So she's keeping everything clean. But when she has movable tissue here, this is the alveolar mucosa. No matter how clean she can keep everything, this piece of tissue flaps back and forth and a lot of plaque accumulates in there. So it's chronically inflamed. So here we have some recession. It's a very narrow band of recession. If we do our Miller classification, we have recession to the mucogingival junction, and we have no loss of interproximal bone or soft tissue. So this is a Miller type 2 defect. We know we can get root coverage here. There will be some periodontists that will say I should do a connective tissue graft. We're going to talk about connective tissue grafts shortly. I did a free gingival graft in this area because it's a small area. It's the lower anterior sextant, and we're not concerned about aesthetics. So I take a piece of tissue from the palate, tack down a simple interrupted suture here to the periosteum, suture here to the periosteum. I made a split thickness bed. Maybe you can see it here. I didn't put it in because I didn't want to turn this into a surgical lecture. This suture that you see here is called a suspensory sling. So I start in the vestibule down here. This suture does not pierce this tissue. It starts, it goes in the vestibule, and I wrap it around the tooth, and I tie the knot out here. So it holds the tissue in place. That's just another technique to hold it in place. And then this is at 1 year. Now, this is why people don't like these in the aesthetic zone, because it has a what we call a tire patch appearance. The color match is not exactly the same. But remember, this is the lower anterior. Her lip comes up to about here. For most patients in the lower anterior section, they have a high lip line in the mandible. So her lip covers this, and this is at a year. And she also had something called creeping attachment. Over time, the attachment creeps up a little bit, and that's why we have all of this right up to here. Although when I sutured it, it looked like there was going to be a little bit of exposure on the root. It creeped up. Is this true attachment? No. It's probably long junctional epithelium, but at a year, she's keeping it clean. So she's keeping it clean. She no longer has this area of discomfort. So we've increased the vestibule. It makes it easier for her to clean. She no longer has the sensitivity and the inflammation. So we've done something good for her. And this would be something that I think most of you would be able to do. There are no neurovascular bundles out here that you'd run into. You'd have to have somebody show you how to do these, but after you're doing 4 or 5 of these, I think you'd very easily be able to do this. Right. That patient that you just saw came in after orthodontic treatment. This patient came to see me pre-orthodontic treatment. Renee Yohei in the ortho department at Rutgers sent her to me. So he was treating her, and there was some recession here. There was a little bit of a cleft in the tissue, and she had a lot of localized gingivitis. So the cleft in the tissue means she lacks the attached keratinized tissue. Plaque keeps accumulating in there, and that's why she's got that localized area of gingivitis. She doesn't have it on these teeth. She's got the same level of home care everywhere. She's got the same bacteria, but she's getting this severe gingivitis here because of the cleft in the tissue, because she lost some of the attached keratinized tissue. So what I did first, some localized scaling and polishing. I cleaned her with the Cavitron, scaled, polished, had her come back in 3 weeks. And just like we have you do at school, this would be the reevaluation. There's a lot less inflammation here. And then I scheduled the surgical procedure. And I simply made a split thickness bed down here. And again, we haven't lost our interproximal bone or soft tissue. I made a split thickness bed. I kept these papilla intact because I don't want to play around with these. I want them there for when Renee does his ortho. Took a piece of tissue from the palate, and I measure it, measure it a little bigger than what I need. I put in a simple interrupted suture there, a simple interrupted there, and again, a suspensory sling that wraps around the tooth, holds it in place. So the gingivitis, when she comes in for the consult, I do some scaling and root planing 3 weeks later, and then the day of the surgical procedure, I complete the free gingival graft. Okay, so this is pre-treatment. This is at 6 weeks, and you can see now we've increased the zone of keratinized tissue here, and you can see the color does not match exactly, and this is at 6 months. So it looks like a patch. So I would never do this in the maxillary anterior section because it's not aesthetic enough. When this first came out in the 1960s, they did it everywhere, and it had good success, but now we have other procedures that don't look like this. But in an area where her lip comes up to here, this is not a concern to me. So now Renee can do the ortho and move her teeth. The reason this is important to do, let me mention orthodontics. Orthodontics is controlled movement of teeth. They put force on a teeth with a wire, a bracket, a rubber band, or Invisalign trays. That controlled force causes the bone to break down. As the bone breaks down, the tooth moves, then the bone reforms to hold the tooth in place. That's controlled movement of teeth. That's what orthodontics is all about. When you have inflammation, inflammation triggers bone breakdown. Inflammation is uncontrolled breakdown of bone. So if Renee did ortho on this, tried to do controlled movement of the teeth and controlled breakdown of the bone in an area of inflammation, the uncontrolled breakdown with the inflammation would take over, and you can run the risk of losing a tooth, getting more attachment loss here. So he's absolutely correct in sending the patient for an evaluation and having that area of inflammation treated prior to starting the orthodontic treatment. And again, for my D3 and D4 students from Rutgers, this is no different than when you do prosthetics. You don't want to start prosthetics where it's inflamed because you just simply will never have a good outcome, and it'll be a headache for you. We don't make you do a re-eval to slow you down. We do it to speed you up, because if we can have an area like this or like this, if they need a little surgical intervention, you're going to have a much better prosthetic outcome. Right. Couple of quick things about free gingival grafts. There have been lots of longitudinal studies that have been done, and periodontists love longitudinal studies. It follows a patient over time. Basically, what they've said is, if you have areas of recession and the patient keeps his mouth or her mouth clean, they're at little risk for more recession. But areas with inflammation will have more recession. So if there's inflammation, you always want to try to do something to correct the defect because you have a greater chance of it progressing. And areas that are treated compared to non-treated areas in the same mouth, same level of home care. So if a patient had a defect on the right side and you treated it, and they had a defect on the left side and you didn't treat it, they followed them over 5 years. And after 5 years, there was no real difference in the treated side or untreated side with increased recession. But the patient has to have meticulous home care. So that's in the patients with good home care. What they found was when they had patients with defects on both sides, if they treated one side, didn't treat the other, and the home care was not ideal, the untreated sides did have more breakdown. So again, these procedures are also predicated on how well patients are doing with keeping things clean and also what you expect dentally out of the teeth. What does that mean? Are you going to put a partial clasp on there? Are you going to expect it to be an abutment for a bridge? Is it going to be a site for an implant? So again, you have to look at the restorative component of what you're going to do. So lateral sliding flaps, we'll talk about those next. So lateral sliding flap, an indication would be you'd have to have thick donor tissue because you have to have tissue lateral to where the recession is. So you have to slide tissue from the mesial or from the distal. If you don't have thick tissue, you have nothing to slide. So a contraindication would be thin donor tissue. Okay, so let's see what we got coming up here. Okay, so this patient came to see me. These two teeth here, this is number 23 and 24. 23 and 24 have provisional crowns on them. He's going to get crowns on these teeth. Luckily, the restorative dentist said, if I'm going to crown these, I don't want you walking around with this. This looks terrible. We got to do something with this. So patient came to see me. He did not have any mobility on this tooth. He had a lot of recession. The recession may be partly due to the position of this tooth in the arch. It was a little bit offset to the buccal. So I do my assessment. I do my diagnosis. He's got recession to the mucogingival junction. He has good interproximal bone and soft tissue. He's a Miller type 2 defect. I can expect to get some root coverage. This tissue here was extremely thick. So since it's thick, I could have done a free gingival graft here, but I would probably only get coverage to here. I'd never get it up to here because this is a big, wide, broad area. So I thought, okay, I'm going to do a lateral sliding flap. A lateral sliding flap is simply get the patient anesthetized in this area. One surgical site, unlike a free gingival graft, which is 2 surgical sites. Get them numb, some incisions around here. I have to create a bleeding edge in this tissue here. And I maintain this collar of tissue here. I don't want to lose any tissue here. So I make an incision here. I come down here and come down here. And I do a split thickness in this tissue. And I just slide this tissue over. And since I've done a split, under here will be periosteum. That periosteum is programmed to granulate in with what was on top of it, which is this big chunk of attached keratinized tissue. So I clean this root surface with the Cavitron. Some people will treat the root surface with tetracycline to detoxify it. They may use citric acid to get some of the bacteria out. You can do those things. You clean it off. So one surgical area. And this is what we've got. All right, so I've done my split thickness flap. I slid the tissue over, so it's thick tissue. I slid it over, I hold it in place. It's attached at the base here, so it gets a blood supply from the base. So the blood vessels are coming in from the base. They're coming there's going to be anastomosis of the vessels on the lateral area here. This is the bone covered with periosteum. This is bone covered with periosteum. This is simply going to granulate in. Now, one mistake I made, I did not leave a wide enough band of tissue here. So when it healed, this is what it looked like at 2 weeks. I started to lose a little bit of tissue on the canine here because I didn't leave a wide enough band here. I left a wide enough band here that I didn't get anything. This did not bother the patient. He was happy with this. And at 4 weeks, this is what he looked like. So we had a little rebound here. I lost a little bit of tissue here and a little bit of tissue here, but this was the tooth that had the recession to begin with. So he lost a little bit here. There's a little bit exposed there from the way the flap was designed, but he was ecstatic with this. So he went on to his prosthetic crowns here, and this looked great. And he did good home care. And so this is just another way. But again, if the tissue isn't thick, you can't do this. I do these a lot in your maxillary first molars because sometimes the mesial buccal root is a little bit prominent. And if there's usually a thick, wide band of tissue distal to that, I can slide that tissue forward. So I do that usually around molars. Right, subepithelial connective tissue graft. It's indicated for aesthetics. It has a very, very good outcome with aesthetics. It's done when you want to get root coverage, and if a patient has tooth sensitivity, it works well. Contraindications for a subepithelial connective tissue graft: the position of the tooth. If the tooth is too far out to the buccal, it's very difficult to do these procedures, because in this procedure, you're putting a piece of connective tissue on an exposed root, and you have to move the patient's own tissue coronally over that. If this tooth is pushed too far out to the buccal, it's very difficult to stretch tissue out over a tooth that's in buccal version. And the amount of remaining attached keratinized tissue can be a contraindication. If you don't have enough attached keratinized tissue, you have nothing to move coronal over your donor tissue, your connective tissue donor tissue. I'm getting crazy now. All right, let's show you some more slides. All right, so this patient had some recession here. We do our diagnosis. Miller type 1, here's a mucogingival junction. We don't probe to the mucogingival junction. We have recession that does not go to the mucogingival junction. Good interproximal bone and soft tissue. He had sensitivity only on tooth number 5, but since he was going to get treatment on 5, I said, if you've got a little sensitivity there, let's treat 4, because you're going to be numb on these teeth anyway. This was treated with a tunnel or a pouch. So what that means is, I didn't put the surgical slides in. It means we get them numb. We do not detach the papilla. We make incisions here, 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 and we make incisions going laterally into the papilla. We raise the papilla and this tissue up off the bone. We slide our connective tissue under there, and we coronally advance this. And this is what it looked like at about 3 weeks. I don't like to cut papilla or make vertical incisions if I don't have to, because then you run the risk of losing the papilla. And you need thick tissue. So this was thick tissue. So that's an indication, because I need to move this coronally. And these teeth are in a good position. They're not too far buccally. So this worked out very nicely. It addressed his issue of sensitivity. In the very beginning, I said to you, some patients come in with sensitivity, and the restorative dentist put some bonding agent or composite on here to help reduce the sensitivity. If that's all it's on, there was a thin little piece of bonding agent or composite. We notice that at the consult visit. We tell the patient that we're going to take it off. And if we take it off, then we can get this. If there was composite or bonding material there, you will never get to this, because you can't have tissue grow over that. So you'd have to flick it out, and then the connective tissue will lay on that and grow into that area. So that's a very common thing that we do. This is just showing you the connective tissue. So this is the device I use. It's a double bladed handle. These blades are set on here to be 1 millimeter apart. So this is all connective tissue that comes out of the palate. The only epithelium is right up here. So there's about 1 millimeter or 2 of epithelium. I cut that off, and the rest of this is all connective tissue, and that's what slides under the pouch. Or if I do make a vertical flap, that's what goes under the flap on the tooth. So let's show you this. This patient came to see me. He had just finished orthodontic treatment. He is 23, 24 years old. He finished college. So he had some recession here on this tooth, and he had some recession here, and he had some sensitivity. So look at the thick tissue here. If we only had this one area here, just this molar, if that was the only thing I was concerned about, I could probably do a lateral sliding flap, because he had thick tissue, but he wanted to do something here. So I said, since we're going to do something here and here, we're going to do a connective tissue graft. And he had enough keratinized tissue here. It's clean tissue. It's healthy. It's thick. I anesthetize him. I make my tunnel. So I do not detach the papilla. I make an incision in here. I raise this papilla, an incision here, raise the papilla. And if this tissue is thin, it's very difficult to raise the papilla. So you need to know you have thick tissue to start with. And I raise the papilla back here. And this is the connective tissue that you saw in the previous slide. Now I've pushed it in under the flap, and you can see how bulbous it is. And I need to pull this tissue down coronally. So when I do this, I do a series of incisions to release this tissue. I'm going to move this coronally. So I'm going to move this tissue coronally over the exposed areas. That's why, again, I said you need to have thick tissue. Contraindication would be if you had very thin tissue. This wouldn't work. And this is the day I sutured. These are 6-0 sutures, and these are polypropylene. So 6-0 polypropylene is almost like very thin fishing line. It's almost like a nylon type material. It's a synthetic material because I don't want to do a lot of tearing of the tissue, and I coronally advance the flap. So I'm covering there, I'm covering here. And this is at 3 weeks. So there's a little bit of rebound here, but my connective tissue is in here, and this will all attach over time. And he was very happy with this. I don't have the 3-month post-ops in here, but he came back at 3 months and it looked pretty much just like this. And he had no more complaint of sensitivity. He was able to eat, drink, and brush his teeth in this area. I didn't do anything on the canine. The connective tissue went up to here, but it was to get in here and to get some bulk in here. Right. And again, with connective tissue grafts, there are lots of studies that show that if you do these properly, you can have very successful results. There are areas where you can do this now where you don't have to take a piece of connective tissue. You can buy connective tissue from a medical supply company. So that's the next thing I want to show you. We use something called a dermal matrix. So a dermal matrix is just a piece of collagen that's been extracted from the skin of a human donor. What does that mean? If you look at this piece here and this piece here, same patient, same tissue, this is a strip of collagen. When people in the United States go through the organ donation process, basically they're screened for all kinds of diseases. Once they're, make sure they don't have any viruses, once they're cleared for organ donation, when they pass away, their body becomes somewhat of a commodity. The bone is used, they harvest the bone, it's used for orthopedic surgery. It's the same bone that we use when we do bone grafting and when oral surgery does bone grafting. The collagen gets extracted from their skin, and we buy sheets of collagen. I buy sheets that are probably 20 millimeters long by 15 millimeters wide, I think I buy 20 by 20 millimeters wide by 20 millimeters long, and I can cut a piece of collagen to the size I want, and I hydrate it in sterile water. Now, what's the benefit of doing this? I say to the patient, I can treat this area, but I have to give you Novocaine on the roof of your mouth and cut a piece of tissue from the roof of your mouth. If you want to avoid that, I can buy some collagen from a medical supply company and I can use the collagen. I tell them, you absolutely have to tell them it's a human product. You can buy collagen that comes from a cow. You can buy bovine collagen. I use the human collagen and I tell them. And if you use bovine, you've got to tell them it's bovine. Tell them it came from a cow. Because I don't know, what if the patient's a vegan and they say they don't want it? You have to tell them what's there. And my consent form has a section where if we use a human product or an animal product, we write it in there. And the patient has to initial next to that they've been informed there's a human product going in there or an animal product, because animal products can come from horses, pigs, cows, and based on someone's religious affiliation or anything, you need to let them know what's in there. You just can't throw something in there without telling them. All right, so that being said, patient comes in with this recession. She had some sensitivity, a little bit of sensitivity. So I told her we have a couple of options. I didn't want to do a lateral sliding flap on her because I didn't want to cause any recession on these adjacent teeth. I told her I could do a conventional connective tissue graft where I harvest tissue from the palate, or I can use the human collagen. She opted for the human collagen. So I can here, instead of doing a tunnel, I can make a tunnel with this. I've done tunnels. This I did with vertical incisions. And I can either do a full thickness flap or a split thickness flap. For this particular procedure, I did a full thickness flap. So I cut the collagen to the size I want. It's hydrated. I clean the root surface. I suture this into place. So you can see sutures going through this material and around the tooth. That's going to hold this down below the gum line. And then I'm simply going to coronally advance the flap over this. So here's the collagen. It's called a dermal matrix. So here's the collagen dermal matrix in here. So I first tack down the papilla, and I've done my diagnosis. I know this is a Miller type 1 defect. So I know with a Miller 1 defect, I can expect root coverage. So I put the dermal matrix in, I tack down the papilla, and then I have to close off the verticals. So I have to put a lot of sutures in here. When I'm done, this is what it looks like. So you can see how bulky this is because I have this big piece of collagen tissue in there. So I've got that in there. All right, so sutures in place with the dermal matrix. 2-week post-op, I take them out. That's what I had pre-treatment. And 6 months post-operatively, there's a little bit of rebound, but it looks a lot better. And she was happy. She had no more sensitivity there. So she was very happy. So that, to us, that was a success. This was another patient in my office, came in. She had recession on the canine. She wanted something done for that. For her, I could have done a lateral sliding flap because she had an enormous amount of tissue here. So I could have slid some tissue from here and not gone anywhere near these. I had explained that to her, and she specifically came in and said she wanted a gum graft. I talked to her about sliding tissue from here. She said, well, what are the disadvantages? I said, well, I could cause some recession here. I don't think it's likely, but I could. She didn't like that. She said, what else? I said I could do a graft where I use some human collagen. And that's what she opted for. And since we were doing that tooth, I had to make a flap here. I just included this additional tooth. So there's the dermal matrix. It gets sutured into place. I coronally advance the flap. I close with my verticals. This I just put in to show you that the suturing has to extend through the palatal to hold everything in place. And you can see how I've bulked this out. And then this is at 60 days. And you can see somewhat of the patchwork of what was there. But then here's 1 year. So this was a great success. The reason this was a success, she had very thick tissue to begin with. Patients that have thick tissue, you can get anything under a thick tissue, and it can be very successful. And good home care. And she had the good interproximal bone and soft tissue that helped with the blood supply to help nourish it. So this is a great success. And let's just say some of you were going to do restorative work on here. What if this patient said, now, after this, I'm going to see the dentist and I'm going to have laminates on these teeth, or I'm going to have some crowns made? You'd want this to be like this because you wouldn't want to start with an area of recession. So there are a lot of things that can be done to help you with your restorative work. All right. So next, we're going to talk about an apically positioned flap. This patient came in to see me. This is what she looked like at the initial visit. Highly inflamed. She had a lot of prosthetic needs that had to be done. Took her through phase 1 therapy, scaling and root planing, and the inflammation has resolved somewhat, but she has a mucogingival defect here. She needed osseous resective therapy in this quadrant. So I know I'm going to be doing surgery for the osseous defects. Instead of doing 2 surgeries, the osseous surgery in 1 visit and a free gingival graft, I just opted to do an apically positioned flap. So that means when she's numb, I'm simply going to do a split thickness flap on the buccal. So split thickness flap, here's the edge of the tissue margin that was up here. I move it apically, there's a suture there, and a suture there. That tacks it down. I do a full thickness on the lingual. On the lingual, I do my resective therapy. All the D3s and D4s that had my lectures when you were D2s, you remember, we do our lower resective therapy from the lingual. I treat these defects. There were no defects here, so I simply apically position this tissue. And then she comes back for her post-ops, and this is at 2 weeks. So now this is granulating in. We've increased the zone of attached keratinized tissue. This is 18 months later, and this is what you all want as restorative dentists. She came in with this. When you treatment plan her, you say, okay, you've got some periodontal problems. You know these crowns have to be redone. By doing the mucogingival therapy, we increase the zone of keratinized tissue here. It acts as a barrier to inflammation. So now look at this at 18 months. So you as a restorative dentist, you want this. You want the periodontist to create this environment for you because the patient's going to be happy. She's not going to say there's bleeding. She's not going to say there's inflammation. So this is good. You want this. And then I did some surgery in the upper also, which I'm not showing you tonight. But again, this is what you ultimately want. Right. Pinhole surgery, we're just about done. Pinhole surgery is just a very specific technique where there is recession. The pinhole treatment only works with Miller 1 or Miller 2 defects. And what they do is they make a hole in the gingival tissue and they have to release this, and they need thick tissue. So they need to do a split thickness flap, and they put, here's a piece of collagen, here's a piece. They put collagen in, and they move the collagen into the area of the defect, and they coronally advance the tissue. So they don't make incisions here. They make incisions here, and then they start to free up this tissue. They have specialized instruments that they use. So those are the 2 pinholes to treat this defect and this defect. And this is what, and these photographs, by the way, are from Lynn Harristy. Lynn is a friend of mine. She's a periodontist in Vermont. And if it wasn't for Lynn, I wouldn't be sitting here tonight talking to you because she's one of the reasons I became a periodontist. Nicest person. Helped guide me, helped mentor me, helped motivate me. So again, she's not here, but thank you, Lynn, because she helped turn me into what I am today. And just a nice person. So this is 3 months post-operatively. We haven't increased the keratinized tissue, but she corrected the recession. And it looks like she got a little more tissue here. And again, this is all with collagen strips that are put into the pinhole. Here's another one that she did. Patient came in. She said this patient had some sensitivity here due to the cervical abrasion. She makes her 2 pinholes. She gets the collagen strips in there. She pushes them down with the instruments to cover the area of recession, very similar to what I did with my connective tissue grafts, except this is a proprietary procedure where you use their specific instruments and their specific technique. And then 3 months later, she has great success here. So she's covered this area of surgical abrasion. The patient no longer has any sensitivity. And again, it only works in Miller 1, Miller 2 defects. We are at the very end. Right. I threw this in here just as one other thing to tell you. This is a patient I came into my office. He had a root fracture. So I extracted his tooth. I did not do immediate fixture placement. I did traditional bone grafting. This is the day he came back for the fixture. So 6 months later, he comes back for the fixture. I put the fixture in. This is when he has the provisional on. And I know the contact points are not closed, but I'm not the restorative dentist. But he came back to see me for a photo. But what I need you to see here is there's a fixture in here, and I have a great deal of attached keratinized tissue here. Because when this ultimately gets restored, you don't want somebody saying to the patient, hey, your tooth looks fake. With the right amount of keratinized tissue, it looks as natural as his natural teeth, and it's going to be the barrier against inflammation. If you do not have that barrier against inflammation, you run the risk of developing perimucositis, and from the perimucositis, you're going to get the potential for periimplantitis. Here's another single unit fixture. Now you can see where I did connective tissue grafts. You can see the line here and the line here. So this is at about 3 weeks after I did the surgery, after the uncovering, because I had to do another procedure to get more thick tissue here. And around this bar, if you're going to put a denture on here, you want this tissue to be your barrier against inflammation, because if you don't have a barrier, if you just rest on mucosa, it's going to be extremely uncomfortable for the patient, and they're always going to be complaining, and they're going to say, why did I spend all this money? So again, these procedures not only apply around teeth, they apply around implants. So what are our endpoints of therapy? Our therapeutic endpoints are we want to be able to increase gingival dimensions around teeth and implants. Doesn't mean total root coverage. It means we want to increase the dimension. In some instances, we will get root coverage, and in other instances, we're doing it for aesthetics. So there are multiple endpoints. So you have to know where you're starting before you know where you're going. And if you have a good plan to begin with, you will have some good success. All right. Conclusions. There were multiple different ways that you can treat gingival recession. Not every area of gingival recession needs to be treated, but I will tell you, if you're going to have orthodontic treatment for your patient, you have to think about treating mucogingival defects. If you're going to do something restoratively, if you're going to put crowns on teeth or have some type of clasps for partial denture, you need enough attached keratinized tissue that's going to act as a barrier against inflammation. And if the patient has areas that are sensitive, you want to try to do something to help correct that so they can enjoy food and keep the area clean. So that's pretty much all I have to say. I want to thank Dr. Rakim. I want to thank everybody at Zufall Health. I want to thank everybody from Rutgers Dental School that tuned in to hear me. I want to thank my residents from Rutgers. I want to thank my Zufall resident crew, the NYU Langone AEGD crew. I want to thank the D3s, the D4s, and all the faculty at the dental school that are listening. And if anybody from the perio department that are faculty, you guys helped make me what I am today. So I have to thank all of you. Okay, I'm done.
Thank you.
Now we can do some questions and answers.
That's great. Thank you so much, Dr. Scorziello. That was a lot of great information. We have 3 questions. Hopefully we could get through them in the next couple of minutes, but I do want to remind everyone that if you are logged in for 50 minutes or more, you have earned your credit. So if you need to jump off at this point, please feel free to do so. So one of the questions is there less collagen shrinkage when utilizing the pinhole technique compared to gingival surgery with a flap?
Well, when you harvest the patient's own tissue, if you take tissue from the patient's palate, you're always going to have shrinkage. So if you use the collagen strips for the pinhole or just the dermal matrix, there really won't be any shrinkage. So yeah, good question.
Great. Yeah. The next question is, I always recommend patients with recession see a periodontist first, obviously, but many prefer bonding. Are there reasons why composite bonding is contraindicated? Does it contribute to continued and worsening recession?
Well, most recession is caused by aggressive toothbrushing. So if you have an aggressive toothbrusher, they have to be broken from that habit. You can't have them aggressively brushing because that will continually be a problem. Bonding is done not, bonding is not done to treat recession. Bonding is only done to help reduce their areas of sensitivity. So if they have sensitivity, the bonding is done to help reduce the sensitivity. So if they want to, but sometimes even with bonding, it'll break down, it can flake off. So if they want to do something different, they have the potential to do some gingival grafting. And again, they also have the, if they have it done, it can also look aesthetically pleasing to them. There's nothing wrong with the bonding, but that's just to help reduce sensitivity. It won't do anything to alleviate the recession.
Thank you. The last question is, how do you classify reverse architecture? Like if you lose interdental papilla without loss of the buccal facial gingiva, or is this not a case patients present with?
Well, reverse architecture is seen usually, that's a term used for the bone when the bone is breaking down. So reverse architecture is something that we would define when we're looking at x-rays to diagnose periodontal disease. That's more related to the bone breakdown. If a patient has lost interproximal tissue and it's lower than the mid-facial tissue, they're not going to have any gingival grafting. It means they have very severe periodontal disease, and it's very likely they may be losing the tooth. So gingival grafting wouldn't be done for them. I hope that answered the question.
Yes, I just lost my Zoom for a second, but we're good. Thank you so much for a great presentation, all your expertise and all your wonderful work and the education that you provide for the residents.
I'm going to have the presentation available. So I don't know how everyone can get it, but the presentation will be available so everybody can download it. So you can let them know how they can get the presentation.
It's already up on our website along with the link. Our team members also shared the link for the survey in the chat if folks want to take the survey right now, or they could find it on our website along with the slides right after the presentation. Once again, want to thank you and thank you all for spending your time with us. Next week, we have Dr. Novi, who will be presenting on how to stop a coccus. Should be equally entertaining. So I invite you to join us again next week if possible. Thank you all. Have a great evening.
Thanks again, all Rutgers, because there's an exam tomorrow, so it took a lot for them to be on listening to me. So D3s from Rutgers, thank you for listening. You guys are the best. Go Team Perio.